Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist and professor and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. Today's very exciting. We're on the heels of the 2026 ASCO GI Cancer Symposium, and I'm delighted to be joined by the chair of this year's meeting, Dr. Mary Feng. Dr. Feng is a professor and vice chair for clinical research in the Department of Radiation Oncology at UCSF, very, very well known in the field, and also serves as medical director of the Clinical Research Network office at the Helen Diller Family Comprehensive Cancer Center. By the way, our full disclosures are available in the transcript of this episode. Dr. Feng, welcome, and thanks so much for being on the podcast today.
Thank you so much for having me today, Dr. Powell.
You got it. And I'll take it with first names from here, Mary. Congrats on a really fantastic meeting. I followed ASCO GI primarily through Twitter, and it really had some tremendous studies showcased, and that a lot of credit goes to you and the brilliant team of investigators who put them together. GI26 had a number of novel therapies, a number of innovations across the multidisciplinary approach that's taken to GI cancers. I wanted to highlight a couple of the studies that rose to the top in prominence. And the first of those is the Horizon GEA-01 study. So just for the audience, this was a study that looked at zanidatamab with chemotherapy, with or without tislelizumab, for first-line treatment of HER2-positive, locally advanced, unresectable, or metastatic gastroesophageal cancer. Mary, take it away. What did the study tell us?
Yeah, we're so excited to hear the results of the study because really it was a test of combining the dual HER2-targeted bispecific with an anti-PD-1. It was a 3-arm international study, so really patients all over the world were involved in this, and the patients were randomized to standard of care with 1 or 2 additional drugs. And we were so excited to hear that there was an overall survival benefit with the combination of the Zani and the tislelizumab. Median overall survival was over 2 years, which is really heartening for this very difficult to treat disease. And in fact, the results seemed to hold up even with patients who had a variety of PD-L1 TAP scores. So this is really an exciting combination and really shows that we're making progress in this disease.
You know, it's interesting. The authors conclude that perhaps this might represent a new standard of care in HER2 targeting therapy for gastric cancer. Thoughts on that? Is this something that folks might see in the clinic relatively soon, or is that tough to say?
It's tough to say how quickly this will get adopted into the clinic, but certainly it is very exciting and very hopeful.
Yeah. You know, it's funny. I started my career in a HER2 breast cancer lab, Dennis Lehman's lab at UCLA. And what I know about you, Mary, that your sister-in-law is Nancy Lynn. Is that right?
That's right. She is breast medical oncologist.
And it's just amazing to me to see these HER2-directed therapies sort of fan out into a multitude of different malignancies. And this sort of bi-specific or bi-targeting approach, I guess you'd call it, with zanidatamab is quite curious. I was really intrigued by that mechanism. I'm going to move on to a different abstract now. So this is a SWOG NRG study, GIO4 SWOG 1610. This is also known as the COMMIT trial. I wonder if you could share with the audience some of the details of that study.
Sure. As you said, it was a joint cooperative group studies, and I just want to put in a plug for cooperative group studies because it is an amazing mechanism to really get phase 3 studies done and redefine the standard of care for many patients. This study in particular was really riding along the heels of a lot of excitement in people who had deficiencies in DNA mismatch repair and have really great, robust responses to immunotherapy, and really looking at whether we can de-escalate treatment for these patients and not sacrifice tumor outcomes. So the study was initiated, over 100 patients were randomized to therapy, and unfortunately it did show that patients who were treated with immunotherapy alone didn't do as well as people who also had the backbone of standard of care chemotherapy. We have a lot of side effects from chemotherapy, and that's why we're trying to de-escalate therapy in patients. But in this case, it was just too much de-escalation, and we still have to fall back on the tried and true chemotherapy.
I saw a lot of the buzz on Twitter around this particular abstract. And, you know, it really centered on the fact that it's so critical for us to get, quote unquote, negative studies out there, right? Just for presentation. I don't know if this would truly be perceived as a negative study in the sense that there was a meaningful difference sort of seen between the treatment arms. Tell us your thoughts on that and sort of the thought processes of the committee in putting this study up on the podium.
Yeah, we thought it was really, really important because not only physicians, but also patients have been so excited about the promise and hope of immunotherapy. And for sure, it is a great treatment for many patients. But is that all we really need? So we really felt strongly that we should present this, as you said, so called negative study to make sure that people were not over exuberant about one therapy and kind of throwing the baby out with the bathwater, so to speak, and just making sure that we're considering tumor outcomes and quality of life both together.
It's interesting. So many questions that I had after seeing this. You wonder about the choice of PD-L1 with atezolizumab versus PD-1 with drugs like Pembro and Nivo. And it's the same sort of dilemma that we have in diseases like renal cell carcinoma, where there's this sort of unexplainable difference between the two pathways. Did some of that conversation arise in the context of this study too?
Yeah, somewhat. Ideally, other studies might be done with slightly different mechanisms of drugs, but certainly we have to pay close attention to them and really do them only on clinical trials.
Indeed, indeed. Another study that got a lot of fanfare, and all these studies have really cool names, is the Breakwater trial. So this was a study presented by Scott Kopet looking at frontline therapy with encorafenib, cetuximab, and FOLFIRI, specifically in that BRAF V600E mutant metastatic CRC population. Tell us a little bit about this study.
Yeah, thanks for bringing it up. As you know, patients with this BRAF V600E mutation tend to do more poorly with current therapies, and they just have a worse overall prognosis. And so, really, there's a lot of effort targeting these patients to really improve their outcomes. So, this was the primary analysis of cohort three. For these patients specifically in the Breakwater trial, and I don't know who came up with it, but it's probably some late night brainstorming session amongst friends. It's usually how it gets started. And these patients had not been previously treated, and they were randomized to the encorafenib and cetuximab or control. And in the study, the primary endpoint was met with an ORR that was quite high of 60 plus percent versus 40% with the encorafenib cetuximab. And actually, very importantly, more than half of the patients had a response duration that exceeded 6 months. So they didn't just have like a 3-month improvement, but really it was fairly durable. And this really gives hope for patients with the BRAF V600E mutation so that we could hopefully get outcomes to continuously improve.
Yeah, that's interesting how, this landscape of frontline therapy of colon cancer is changing so much. I mean, for the longest time when I was a fellow, it was just Folfox or bust. And it's really, evolved so rapidly to incorporate these targeted therapies. It's pretty wild.
Yeah, it's a really exciting time right now where just new drugs and drug combinations are coming up. And we just need to be able to continue running these trials to test them.
Indeed, indeed. So you brought up the concept of folks getting together late night and assigning names to these trials. So that's probably the perfect segue to the disco trial, right?
Yes, right.
It's a really creative study design. And I'll maybe have you explain it for us. That really incorporates MRI. I believe it's in sort of staging of colorectal cancer. Maybe you could tell us a little bit more about this.
Sure. This was a really interesting study, and it shows how fun the Dutch are. This is a study that involves 7 Dutch centers and 1 Chinese center to get a broad population. And almost 300 patients who had colorectal peritoneal metastases were randomized to standard of care peritoneal staging versus diffusion weighted MRI, which is a special sequence that can be done on most MRI scanners. And what they were really looking at is whether patients who had colorectal peritoneal disease could be spared futile surgeries. So, surgeries where we used to call them shriek and peek, like an open and closed surgery, where they went in hoping to do something that would actually help the patient, took a little look around, and the disease was more extensive than they expected and had to close up. And in doing that, then patients would have a futile amount of pain, cost, financial cost, and delay of future therapy. So, what they were trying to do is find out if there was some non invasive way they could prevent these futile surgeries from happening. So, they randomized patients to getting this special MRI or not. And they actually found that they were able to reduce these futile surgeries by 20%. So, from over 40% to about 20% of patients having them. Now, it's not zero, it's not perfect, but that's a real number of patients, 20% of the overall cohort that was spared the pain and suffering of a surgery that wasn't going to help them.
Oh, that's so interesting. I have to say, peritoneal mets, in my opinion, are sometimes some of the most vexing metastases to diagnose. In renal cell, we're primarily using CT scans, and it's challenging, I think, from the radiologist perspective to really discern much in the way of, what's really sort of present in the abdomen. Is that true also in GI diseases, I take it?
Yes, it's definitely very tricky. And I find that it's kind of an institutional preference, whether people use MRI or CT to stage the peritoneum. Certainly, the CT is faster, so it's not as subject to breathing artifact, which is the issue usually with MRI. With the diffusion weighting scans, they are meant to be free breathing scans anyway. And so that looks at the differences in diffusion of water. And I think that might be the difference between standard MRI versus CT staging and diffusion weighted MR.
Got it. We're going to switch back for a moment now to sort of the upper tract, if you will, and discuss this trial looking at neoadjuvant chemo followed by surgery versus neoadjuvant chemo and chemoradiotherapy followed by surgery versus neoadjuvant chemoradiotherapy alone for resectable gastric cancer. This is the so-called Critics 2 study. I hope I got the randomization right, but can you tell us a little bit about what the study showed?
This study was really aiming to optimize neoadjuvant therapy that would be added to surgery for gastric cancer. As you know, the surgery is the mainstay of treatment for this. And in the past, neoadjuvant and adjuvant strategies have both been employed, but after a large surgery, it's very difficult to get patients to that adjuvant part. So, just as in rectal cancer, a lot of people are kind of focusing in on this total neoadjuvant therapy concept to make sure that the patients actually get systemic therapy at some point, which is easier to be administered in a neoadjuvant setting. So, they took a look at three different strategies for neoadjuvant therapy. One was chemotherapy alone, one was radiotherapy alone, and the other was combination of chemotherapy and radiation. And at least with the chemotherapy that was used in the trial, which was a combination of docetaxel, oxaliplatin, and capecitabine, the combined therapy arm had the best outcomes, with the chemotherapy alone arms faring a little bit worse than the other ones. And really, in terms of event-free survival and also overall survival, the outcomes were pretty consistent between those two endpoints. This is certainly intriguing that multimodality treatment was better with chemoradiation was better than chemotherapy alone. What we don't really know is what would happen with other chemotherapy combinations if they had been used. So it's definitely intriguing and really fits the strategy of moving therapies up prior to surgery, because as we know, this is quite a systemic disease. And any way we can get therapy into patients is better than trying at the end and not being able to have patients tolerate therapy.
Indeed, it's such a balance of quality of life, right? Because I do think that, some of these modalities, chemoradiation, et cetera, do certainly add some burden to the patient. But I think you're absolutely right. We need these randomized trials to help define what the optimal approach is. And this is maybe one step towards doing that. The last abstract that we're going to cover really sits in, I'm not going to say the most controversial space, maybe the most exciting space, which is the potential that we could do something simple like exercise and potentially have, some benefit to our patients with colon cancer and perhaps other diseases as well. This was a longitudinal assessment of physical activity. My understanding is this is all sort of self-reported in the context of the ColoCare study. Can you tell us about this abstract, Mary?
As you said, this is in many ways a really exciting study because it is something kind of a medicine or a therapy that could be free. Imagine that. So, really, this is a longitudinal study that took a look at patient questionnaires in almost 2,000 patients, as you said, in the ColoCare study. For everybody who's listening, that was a study of newly diagnosed patients who had colorectal cancer across all stages, metastatic and non metastatic. And so they filled out a validated questionnaire asking about physical activity. And that was grouped into basically walking, moderate, or vigorous. And in this study, they were trying to see if there was a correlation with outcomes in patients who had more physical activity or less physical activity, whether it mattered if they had metastatic disease or non-metastatic disease. What they found is that patients who had non-metastatic disease, just simple walking actually showed the most consistent benefit at reducing fatigue and quality of life. More vigorous exercise wasn't better. So more is not always better, at least in the first year after diagnosis. After the first year of diagnosis, more activity was associated with better energy and improving quality of life. But in that first year, just taking walks made the difference. So really, this is the most actionable of all the abstracts, I think. We could start telling our patients with colorectal cancer that they should go take walks, like literally today or tomorrow in the clinic. So that's why this abstract was chosen and is really exciting.
Totally not evidence-based, but I do have a large cohort of long-term survivors with metastatic kidney cancer. And one thing that they do have in common, maybe I need to investigate this further, is they're all very avid walkers. Some of them do 6-7 miles a day. It's remarkable to me. And I bet I probably could do half of that myself. It's quite impressive.
Yeah, I hear you. I think walking is probably not only like physical therapy, but emotional, mental therapy. It's very complicated to see exactly what the mechanism is, but just this simple action of encouraging patients to walk seems to be really helpful.
Indeed, indeed. Mary, what are we missing? Any other major highlights from the meeting that you wanted to shout out before we wrap up today?
One major highlight was that we had a keynote speaker, Cameron Rathmell, who is CEO of the James. She spoke about really deepening relationships between academic and community centers to really take better care of our patients, specifically in the context of clinical trials, decentralizing clinical trials so that we can actually accelerate the progress that we make and have more presentations at GI ASCO by allowing patients access to these clinical trials and still stay at home instead of traveling to major centers. The other thing I always want to highlight is the effort that the planning committee put in. Everybody who reviewed hundreds of abstracts in each section, and the ASCO staff who make the meetings what they are. They run so smoothly. I'm so thankful to all of them. And I hope you're able to come to GI ASCO 2027.
Well, I have to tell you, as a GU investigator, you've really compelled me to maybe attend the next ASCO GI. Maybe I'll give it a shot. Lots of great data. Thank you so much, Mary, for sharing your great insights with us today on the podcast and really for all of your hard work on this really incredibly robust program at the 2026 ASCO GI Cancer Symposium.
Well, thank you so much. I think I will be dropping by ASCO GU, so maybe I'll see you there.
Well, Mary, I know I speak for all of us in the GU community in saying that we would love to see you at ASCO GU. Felix Feng was a dear friend and colleague to so many of us, and we always have and still do hold him in the highest of regard. And my understanding is that there's some very important and critical funding efforts that have been designated in his name. Can you tell us more about that?
Sure. Felix Feng was my husband and a GU researcher, and Felix really was committed to cancer research and making sure that patients could live longer and better, even with a diagnosis of cancer. So after his passing, friends and colleagues at ASCO started a career development award in order to fund investigators who are making that leap to independent academic careers. There is a link that can be shared where we can really donate as a group and continue to fund Felix's legacy, which was really the next generation of cancer researchers.
How terrific. What a wonderful way to sort of honor Felix's legacy of really doing exactly that, mentoring the next generation of scholars in our field. I'll make sure that we include a link to that in our byline here for the podcast today.
Thanks so much, Monty.
And thanks so much to our listeners, too. You're going to find links to the abstracts discussed today in the transcript of this episode. Finally, if you value the insights that you heard today on the ASCO Daily News podcast, please rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.